Hello and welcome. Thank you for joining us today. Today, we are going to talk about the emergency care of patients with cancer receiving CAR T and bispecific antibody immunotherapies experiencing serious adverse events. Now, you have to say that 7 times fast. Today's program is going to be supported by an independent grant from Janssen. We also just need to note that this activity may include discussions of products that are off-label, as there's not a lot of on-label. Currently by the FDA, okay? And I'm your moderator. My name is Alexa Mira. I'm a physician at The Ohio State University. I am a rheumatologist that lives in the Division of Oncology and started the Immunotherapy Management Clinic. And joining me today are 2 amazing people, Marianne Davies and Irene Lebec. And I'm going to let Dr. Davies introduce themselves first.
Thank you, Dr. Mira, and thank you for having me. Marianne Davies, I'm in practice as an oncology nurse practitioner at the Smilow Cancer Hospital, the Cancer Center, and also a program management for developing care signature pathways for management of patients that are on these types of toxicities. So I'm thrilled to be here. Thank you.
And Dr. Lebec.
Hello, it's an honor and a pleasure to be here with you both today. My name is Irene Lebec. I'm an associate professor in the Department of Immunotherapeutics and Biotechnology at the Jerry H. Hodge School of Pharmacy, Texas Tech University Health Sciences Center. I'm an oncology pharmacist, but also have a research lab focusing on immunotherapeutics.
So as you can see, we have a great team, so we're going to talk about some really important topics. First, our first learning objective today is to evaluate the effect of chimeric antigen receptors, or CAR T, and bispecific antibody therapies on the immune system in patients with cancer. And then our second learning objective is to utilize best practices for the diagnosis of management of patients. So patients that are getting T-cell directed therapies, whether it's bispecific or CAR T, experiencing cytokine release syndromes, what are the best practices and how should we be thinking about this? And when they come into the emergency room, how do we kind of identify that? And then finally, our third is how do you integrate that into your practice? Right? How do we receive this? How do we deal with this no matter where you are? That the diagnostic management, the treatment management for people receiving T-cell and bispecifics to treat these CRS-like diseases. So we're going to talk about a quick introduction today. So the whole world of CAR T and bispecific has kind of exploded in the last couple of years, and I think if there's not a biotech new company or an ad or a different thing that's not about this. So it can be a little overwhelming. But we're going to talk specifically more about the T-cell, again, so the CAR T-cells and bispecifics. And I know there's some other immunotherapies and vaccines for cancer treatments, but we're just not going to talk about those today. So Dr. Lebec, can you talk a little bit about the kind of the CAR T and bispecific antibodies?
Yes, I'd be happy to. So let's first take a look at the CAR T therapies. So in this table here, you will note that tasigin-lec-leucel was the very first of these agents to be approved in 2017. And since then, there are now a total of 7 FDA-approved CAR T therapies for the treatment of various B-cell lymphomas and leukemias and multiple myeloma. So from this table, you will see that 5 of these CAR T therapies, they target CD19. This is an antigen that is overexpressed on almost all malignant B cells. And then the last 2 of these therapies, they target BCMA, also known as B cell maturation antigen, which is involved in the pathogenesis of multiple myeloma. So 7 CAR T therapies in the last few years is a huge amount. Let's also take a look at the bispecific antibodies. So in this drug class, you will see there's more than this if you include all bispecific. So they are a special class of antibody therapeutics in that they target 2 different antigens, whereas traditional antibodies only target 1. Within the bispecifics, you can see that they can be further classified by the antigens that they target. So amivantamab, the one at the top of the list here, is one example of a bispecific that targets 2 different tumor-associated antigen. In this case, is EGFR and c-Met. We will be focusing today, though, on the other type of bispecific antibody called the T-cell engager bispecifics. So they're called this because they target a tumor antigen along with CD3. So this is an antigen that's expressed on almost all T cells. So of these T-cell engager bispecifics, there are currently 9 of these agents approved, mostly for hematologic malignancies, but a few also have indications in some refractory and recurrent solid tumors. So before we go into the details of these T-cell directed immunotherapies, I'd like to just point out some major differences in comparisons with immune checkpoint inhibitors, because the immune checkpoint inhibitors right now have also exploded and they're widely used, and there are some very distinct patterns of immune toxicities with our T-cell directed therapies as opposed to the checkpoint inhibitors, largely related to their different mechanisms of action. So just first in terms of production, you can see that each CAR T treatment is developed specifically for a patient. And so this can take several weeks, while the bispecific and immune checkpoint antibodies, these are off-the-shelf products. The CAR T cells, they only require a single dose because they're expected to persist in the patient's body, whereas the antibodies, they undergo systemic clearance and they need to be redosed. In general, the toxicities associated with all these agents are immune-mediated, but they vary in terms of frequency and severity. And it's usually much higher with the T-cell directed therapies than the checkpoint inhibitors. So moreover, you'll see that the toxicities associated with the T-cell directed therapies are usually attributed to acute cytokine release and overactivation of lymphocytes and macrophages, while the toxicities associated with the checkpoint inhibitors are mostly attributed to activation of autoimmune responses. So the toxicities of the T-cell directed immunotherapies are due to their unique mechanisms of action. So let's take a closer look at how these agents work. So here you see in this diagram, just an overview of the CAR T therapies. So first, they're produced by isolating T lymphocytes from the patient's own blood, and then introducing a gene for the chimeric antigen receptor into these cells using a viral vector. The cells that successfully express this new chimeric antigen receptor protein are then expanded and infused back into the patients. A unique feature of this chimeric antigen receptor is that it binds the target antigen and also stimulates the T cell to proliferate and become activated. So enabling the CAR T cells to grow in number and to seek and destroy the cancer cells. The activation and proliferation of the T cells and the killing of the tumor cells results in the massive release of many different cytokines and other inflammatory molecules. And so this is believed to be the cause of toxicities such as cytokine release syndrome, immune effector cell associated neurotoxicity syndrome, which we'll call ICANS, and IECHS, which was formerly called MASHLA, or macrophage activation syndrome, and hemophagocytic lymphohistiocytosis. We'll just call it IECHS. So these are usually characterized by blood abnormalities, such as hypogammaglobulinemia and various different cytopenias.
So can I just make a quick statement, Dr. Lebec, because I think there was a lot of information before we go to the bispecifics. So just really quickly in all of these different things. So the CAR Ts, right? So it's kind of like a bone marrow transplant light, if I'm understanding. You give someone some sort of your lymphocytes, and then they go off to a black box of pharma where they do some magic genetically, very specific magic, where they vector and they activate the CAR Ts, and then you have to give the person immunosuppression, and then you give them the T cells to fight the cancer. This is done at the moment in the hospital, correct? Is my understanding, is that correct?
Yes, so the cells are usually taken from that specific patient, not a separate donor usually. Taken out, the magic happens. They grow the patient's own cells. They will give chemotherapy as a conditioning regimen, and then they will reinfuse the cells back into the patient's body.
And most of the side effects, the ICANS, the CSR, CRS,
CRS.
release syndrome, and the IEC happen mostly often in the hospital. So we're going to talk about that because they're inpatient. And I know this is important as pharma companies are moving to off the shelf. So the idea that it's not your own, it may not be in the hospital, so you can get this as an outpatient and just show up in the ED. So this is why this is becoming more and more important of things we're looking for. So how does this differ then from the bispecifics? Because they are different, though it's a BiTE and a CAR T. Lots of, we have mnemonics. So how are those different?
Yeah, so those are great points. So let's compare the CAR T mechanisms to those of the bispecific antibodies. So the bispecifics, they actually have pretty complex pharmacokinetics. They're dependent on their size, the relative affinity for the tumor antigen versus the T cell antigen, and the relative infiltration of T cells in the tumor microenvironment. So when the bispecific antibody, remember, it targets two different antigens, one on the tumor cell and one on the T cell. So when it binds these two target antigens, it effectively brings together a T cell with a tumor cell. And so this forms an immune synapse. So when this happens, the T cells are engaged and stimulated to kill the tumor cell that it's in contact with. It also releases a lot of cytokines that can not only kill the tumor cell it's in contact with, but also tumor cells nearby. And then the T cell, once activated, can go on and continue to kill additional tumor cells. And some of these cytokines that are released also trigger other immune cells nearby then to recognize and kill tumor cells, even if they don't express the target antigen. So we call this the bystander effect. So you see, one of the main differences is that the CAR T is the engineered activated T cell itself, whereas the bispecific antibody is a protein that will engage and pull together the T cell and tumor cell, and that leads to the activation of the T cell that's already in the body.
That was super helpful. Excellent explanation. I actually feel like I could see that in my head. So are there different toxicities then for the bispecific that we have to think about?
Yeah, so there are some similarities and also some major differences. So if we just look at the pathophysiology, so here are a couple of slides to just kind of summarize this. So both agents, their toxicities are associated with the hyperactivation of the immune response. So this is one of the major mechanisms that underlie these side effects. So whether and to what extent the patient will exhibit these immunotoxicities is highly dependent on a lot of different things, such as patient-specific factors, the type of cancer, the tumor burden, any underlying comorbidities, whether or not they're already predisposed to certain neurotoxicities. There are also treatment-associated factors. For the antibodies, it can be dose or concentration dependent. There's also a very unique time course for these toxicities. And then other immune factors, such as the different cytokines that can be released and their localization. So I think in the next figure, you can see that also the CAR T therapies have very unique toxicity concerns. So one thing with the antibodies is that it's a protein, and like all antibody therapeutics, they will be cleared eventually. The CAR T cells are very unique because they are live cells, and they're expected to persist and stay in the patient's body. So once they're administered, it can be very difficult to predict how they will affect the immune homeostasis. And there's the potential for delayed toxicities, off-target and off-tumor immunotoxicities, and even autoimmune responses. So Dr. Miro, you mentioned timing and why this is particularly important if we are going to try to develop an off-the-shelf T cell therapy, because right now, every T cell therapy is individually made, right? And so there are definitely a lot of advantages if we can develop an off-the-shelf product. So with that are some concerns in terms of recognizing and managing the immune toxicities. So you can see in these graphs here that the CAR T toxicities generally follow a very characteristic pattern. So initially, infusion of the CAR T cells results in acute cytokine release. So this is what we call cytokine release syndrome. This is usually in the first week of treatment. And then these cytokines, you can see on the very bottom graph, they'll eventually kind of go back down to normal levels. But then the T cells that have been infused in will start to proliferate. And so with this proliferation, there's a second wave of cytokines that are being released. And this second wave happens usually in the second or third or even third week. And this is associated with the development of ICANS, the immune-related neurotoxicity syndrome. So in addition to that, there are other delayed toxicities. They're usually more unpredictable and can be autoimmune in nature.
That's why, people ask me all the time, why is a rheumatologist talking about cancer treatments? One is we're just stealing your treatments for cancer and trying to use them in autoimmune disease. So we got to get a better understanding. Two, because, when you think about autoimmune disease in like rheumatoid arthritis and lupus, we don't know what causes that, right? It's the right genetic host or your makeup and a right environmental stimulus. So now we're immunomodulating or actively messing with the immune system to change it, not just suppress it like in traditional chemo. And then opening the door to autoimmune disease, it doesn't take a lot for those cells, as you said, to go rogue kind of and attack other things. So now that we have an understanding of what CAR T and BITE cells is, because obviously everyone should know what those things are now, because you're walking in the emergency room and you'll be quizzed later, right? And then two, what does it mean then when we're really thinking about what these, alphabet soup of these syndromes are that we should be looking for, and how do we really think about these? Dr. Davies, let's kind of go into the diagnostic ways of thinking about this.
So thank you very much, Dr. Lebec, for the presentation and laying the groundwork, and also for Dr. Mayer for the question. So the diagnostic workup is really going to be critical. And you mentioned initially that most of these therapies were done predominantly in the hospital for the whole duration of the conditioning, as well as the post-therapy and evaluation. But there actually is movement in some larger centers to be moving both of these therapies into the outpatient setting for select patients. And that is obviously to be determined, but patients that perhaps can be very reliable and live close by, that can undergo close monitoring. But this then opens the door to a lot of additional specialists that may come across these patients in their practices, even urgent care centers or emergency departments, et cetera. So it's really important that we continue to educate people about this side effect profile. So the three most common toxicities associated with the CAR T therapy are CRS, which is the cytokine release syndrome, ICANS, which is the immune effector cell-associated neurotoxicity syndrome, which is a neuropsychiatric type of syndrome, and then the HLA that we also mentioned, which is now the IE, which is the immune effector associated process. So we'll start with CRS. And one thing I want to say about all of these is that there's not one single test that we can do to say, oh, we did this one blood test and this means you have CRS or ICANS or HLA or HLH. It's really a collection of a symptom presentation. So CRS presents with fever, hypotension, and hypoxia. So all patients need to have their vital signs monitored on a routine basis. And we'll go through that algorithm shortly. But because it is an inflammatory process, an acute systemic inflammatory process, there can be inflammation of any organ system. So for cardiac, there may be a drop in ejection fracture, there may be arrhythmias. Patients can present with pulmonary edema, pleural effusions, GI toxicity such as nausea, vomiting, diarrhea, hepatic with elevations of LFTs, renal with nephropathy or AKI. And coagulopathies, which are really unique to this group of toxicities. There can be thrombosis and even in more severe cases, DIC. So for ICANS, some people may have read in the literature, it used to be referred to a long time ago as CREST, so that cytokine release encephalopathy syndrome. So if you have some vague recollection of what that used to look like, there are a couple of tools that we can use for assessment. One is called the CAR-TOX 10. So CAR T therapy, toxicity 10. Another tool is called the ICE assessment, which is really kind of a modified tool. The ICE assessment looks at 10 characteristics, mostly looking at orientation, cognitive function. There's 10 questions. You should score a 10. If you don't score a 10, then that means you're neurologically declining. The CAR-TOX 10 expands on that and also looks at whether a patient's having seizures or if there's increase in intracranial pressure or motor dysfunction. And for the HLH, this again is the hematologic side effect that can occur, which is unique to the CAR Ts more so than the bispecifics. Patients may present with fever, inflammation of organ systems, so inflammation of lymph nodes, the liver, spleen, etc. And so what we see is a collection of hematologic toxicities with this, with elevation of ferritin level, which is fairly specific to this syndrome, a drop in fibrinogen, there will be a decrease in white blood cells, a decrease in your NK cells, natural killer cells, but then also associated renal toxicity, hepatotoxicity, et cetera. So those are the three most common toxicities that we can see with the CAR T. Now, you mentioned with the preparation for CAR T, Dr. Lebec, that these patients get cytotoxic therapy prior to getting their CAR T infusion. And so it really requires there to be that differentiation between what is that exactly is that cytokine release syndrome versus tumor lysis syndrome, which can also be a life-threatening complication that patients can get. So the CRS is that inflammatory cytokines are released, and those cytokines can include interleukins, interferons, TNF, tumor necrosis factor. There's activation of the T cells, the T lymphocytes, macrophages, endothelial cells, and those kind of infiltrate into the circulation. They may increase capillary leak syndrome and lead to coagulation kind of dysfunction, and all of the other organ dysfunction that I mentioned previously. So cardiac dysfunction, respiratory, GI, hepatic, renal, et cetera. And that again is that inflammatory process that leads to those organ toxicities. Tumor lysis syndrome differs in that it is due to the anti-cancer therapies that we administer. So the cytotoxic agents that we give lead to tumor cell death. And if somebody has really big, what we call bulky disease, a very heavy disease burden, if that destruction of that tumor cell is really overwhelming, if they have a great response to that cytotoxic therapy, that immense cell death is going to lead to a lot of that kind of debris, intracellular debris that's in circulation. And it really is that intracellular contents that causes the complications leading to tumor lysis syndrome. So when a cell breaks down and lysis and breaks down, things like fragments of DNA are released, electrolytes such as phosphorus, calcium, potassium are released. So there's this serum surge of patients who can develop hyperkalemia, hypercalcemia, hyperphosphatemia, and that leads to things like for phosphorus and even potassium and calcium, but severe cardiac arrhythmias, neurologic toxicities with weakness, confusion. It can even lead to coma, and obviously even death with complications of potassium. So these patients are typically when they're getting the cytotoxic therapy for CAR T, they're typically hospitalized at this time. So they're monitored very closely for their electrolytes. And the treatment of management really is very aggressive IV hydration, trying to flush the intracellular contents out, and then other medical interventions that really pull off those electrolytes to help stabilize. So you're going to be mostly concerned with patients that have really high tumor burden that they may present. So that's really the difference between those two syndromes. And then when we look at the cytokine release syndrome on its own, we know that we've seen, and it's been reported that there's been cytokine release syndrome in other conditions, even COVID. So that certainly is of interest to any of us that are treating patients in an urgent care center or in the emergency department, et cetera. So The CRS itself is not only associated with systemic inflammatory systems, but it can also, as I mentioned before, cause an activation of the coagulation pathways, including an activation and release of endothelial cells or breakdown of platelets, triggering the coagulation cascade and fibrinolytic syndrome. So for primary HLH, what we see is a severe, the pattern of what we'll see in the blood work is a severe consumptive coagulopathy. Frequently with that, you'll see also DIC and an increased risk of bleeding. The CRS that we see with CAR T therapy differs a little bit, where there might be mild consumption of the mild consumptive coagulopathy and thrombosis, less so bleeding, very minimal bleeding with the CAR T CRS. Whereas COVID rarely has like consumption of your coagulation factors, but there is an increase in the thrombosis. So those are some helpful hints for how those kind of present. Of course, it can be very confusing because a patient can have had a CAR T therapy and still acquire COVID. So it becomes really a diagnostic kind of really challenge for caregivers.
Well, that's why we have these things, so you can know that you're not alone, and also who you need to call, not just Ghostbusters, for the help, and how you can find someone that if you don't know the right place or the website and some of those places you were talking about for those diagnostic workups and either the NCCN guidelines, ASCO guidelines, CEC oncology, how we can find those information.
I mean, those are great resources. And actually that's, I'm most familiar with the NCCN guidelines myself, but even SITC, the Society for Immunotherapy and Cancer, is another great resource. And there are other organizations now that are really putting together a lot more of these kind of tools. So when we think about, just kind of to take a step back and say, okay, when we think our patient now has CRS due to their CAR T therapy, what's the first thing we have to do? Well, we monitor their baseline vital signs because by virtue of CRS, it's affecting their temperature, their oxygenation status, and their blood pressure. And we grade that. And there are a few different grading criteria that are out there that have been used. The one that is listed here is similar to the NCCN, but there's also the American Society for Transplantation and Cellular Therapy. They are fairly well aligned. So grade 1 toxicity are those that are non-life-threatening. Patients may have vague myalgias, have a fever, and most of the time, those patients just need supportive care. So let's say hydration, antiemetics, antipyretics for their fever. Grade 2, if you now have impact on your blood pressure or oxygen, so you're more hypotensive or hypoxic, these patients, again, supportive care, and typically they can be managed with fluid resuscitation, so IV fluid boluses, maybe some oxygen support, and then the analgesics. And then in some cases, some institutions will even institute a vasopressin at grade 2. Grade 3 and 4 are really when your toxicity is getting much worse. And so this requires more extensive intervention. And that is in the way of introducing an IL-6 therapy such as tocilizumab, which is going to reverse that CRS process. I'm going to take one little step backwards. Because of the pattern of how these can present, as Dr. Lebec said, in most organizations, patients should be be assessed for CRS. At our organization, it's every 8 hours. 8 to 12 hours, and even for the ICANS, every 8 to 12 hours, because it can be very rapid with the onset. Once they develop that toxicity, then it's much more frequent monitoring to assure that the toxicity is not moving from, let's say, a grade 2 to a grade 3, where they require more aggressive intervention. With worsening CRS, patients tend to require vasopressor support. They may even require ventilatory support for a short bit of time. TOCI is the treatment of choice initially. Usually with a CRS due to CAR T, we hold off on using corticosteroids to see if they're going to improve on the tocilizumab. However, if they also have concurrent ICANS, concurrent neurologic symptoms, then the more severe toxicity will kind of predominate, and so they may have to start to get steroids earlier. I will tell
Can
you
I
that
just say, can I just interrupt? I thought that
Sure.
was really good, important point as you're monitoring them. So those are the people in the hospital. As if in the emergency care, now that this is happening a little bit more outpatient too. So I just want to remind people, therefore, then you're asking the patient if they have cancer, ideally we should know that. Two, when they had their CAR T, so how far along? Because if they, now that every different clinical trial or some is just being done, if they've been discharged and we're 72 hours out or different things, that's really helpful to know. So we can't forget that in the asking of the questions, because since they won't be in the hospital and they're not monitored every 8 hours, I doubt that they're going to be monitored in the outpatient every 8 hours. So I think it's, yeah, so I just want to bring that up.
And great point in that. One is that because grade 1, grade 2 really has to do with a febrile presentation, if they're just coming off their conditioning regimen, they actually may have febrile neutropenia. So that's kind of one of our points. So you've got to make sure that you rule out febrile neutropenia, because they also may need an infectious disease consult. They may need to be started on antibiotics as well. So there can be the overlapping toxicity. So important to understand that. I will tell you, there are really not a lot of organizations that are moving this treatment into the outpatient setting right now. I will just tell you some best practices from my organization is that in the electronic medical record, any patient that receives CAR T therapy or bispecific, there is a red banner that automatically flashes on their chart. And specifically, if anybody attempts to order any corticosteroids, it has kind of a stop banner that says, make sure you check with that treating oncology team to assure that they're intricately involved in that supportive intervention, such as the tocilizumab and corticosteroids. Again, these are just some kind of safety parameters that we've put into place at our organization, and some of my colleagues across the country have very similar types of things. That we are guiding the emergency department to contact the treating provider immediately so that they can help guide that the next step intervention in terms of the TOCI and the corticosteroids. So really that collaborative intervention is key. Now, of course, if a patient does present with the higher grade 3, 4, and they require ICU care and use of pressors, et cetera, and ventilatory support, then that management, it kind of trumps everything at that particular point so that they get the appropriate safety interventions.
You mentioned that if they're getting CAR T, one of the first things is that one of the first treatments that you maybe don't want to go to in terms of avoiding the corticosteroid, right? So I know that with the checkpoint inhibitors, one of the concern is that, it could affect the anti-cancer effects of the checkpoint inhibitor. Is this a similar case here?
So there is some thought that the corticosteroids use early on and with the CAR T actually can impact the effect of it. So that is the reason for not using it. Back to the immune checkpoint inhibitor, if you need to start corticosteroids, if the patient had been on the immune checkpoint inhibitor, just a little aside, for a bit of time, it doesn't, use of corticosteroids to manage an immune-related adverse event does not negate the therapeutic benefit you've gained from that immune checkpoint inhibitor. So that's something that we really try to educate our patients about so that they're not worried about reporting any toxicities. So that's always a concern. So that's the CRS. ICANS I mentioned with the neurologic response and the inflammatory. Basically, what happens? There's an acute inflammatory response, cytokine release, and that causes a disruption in the blood-brain barrier, and then an accumulation of the cytokines in the CNS. And that's what leads to those neurologic side effects. So I mentioned the ICE score and the CAR-TOX are really very important and should be done every 8 to 12 hours monitoring for that. So we do have a kind of a slide with a graph that kind of outlines the different grades of the toxicity and how they vary. So for CRS, no hypotension, no hypoxia, but they do have a fever, that's grade 1. As the grade increases as they become more hypotensive and more hypoxic, needing ventilatory support. You can see on the chart for the ICANS, if the patient's low grade, meaning they have a good ICE score, they're able to get all 10 questions correct on that. But if they have 7 to 9 and then start to have a decreased level of consciousness, but no seizures, no edema, no weakness. That's a grade 1. And then we rapidly can move to grade 3 if they have a very poor ICE score, depressed level of consciousness, motor effects, focal deficits, etc. So that's just kind of a comparison, but those can occur concurrently. And so you manage by the highest grade toxicity always. We mentioned the HLH MAS before, and kind of the new acronym is called the IEC-HS. So you might see those kind of used interchangeably in the literature, just to be aware of it. And so basically, what we're assessing here under the CARTOX evaluation is the ferritin level, which is going to be elevated. And in order to say that the person has this syndrome, is that they've got an additional 2 symptoms or signs. They've got an elevation in their bilirubin or ALT, AST, renal side effects like oliguria, increased serum creatinine, pulmonary edema, etc. The ASTCT criteria is a little bit different, and they also add additional manifestations that may be present just to help in the grading of that presentation. The management, if a patient does have the suspected HLH or MAS, is that, so they've got the serum ferritin greater than 10,000, and one of the other following organ system dysfunctions. And we manage it very similarly to how we manage the CRS. So if they've got that presentation, we manage it as though it's a grade 3 CRS with the anti-IL-6 therapy plus corticosteroids. And again, follow-up laboratory like every 48 to 72 hours. So additional things just to kind of consider the timeline of the CAR T therapies is that not only do patients maybe have the side effects from the CAR T therapy, such as the CRS and the ICANS, but other acute toxicities may be that they are neutropenic. If they need to start on steroids or receive TOCI, then they're further immunosuppressed. These patients are at really high risk for opportunistic infections such as bacterial, viral, and fungal. And in the more acute phase, and even in the delayed phase, they then have impaired cellular and humoral immunity, and so still at risk for pneumonias, respiratory viruses, and even pneumocystis. So we've got to continue to be really diligent in monitoring for these potential late effects. And more late effects for that are hypogammaglobulinemia, which increases a patient's risk for leads them to be fairly immunosuppressed. Some of the late complications, again, patients may, if they've been heavily pre-treated, they may not have a bone marrow that's going to recover really well, so they may have long sustained ongoing cytopenias from their earlier toxicities. If they have late developing cytopenias, we may be concerned that maybe they've got recurrent disease or secondary malignancy. Again, I mentioned the late infections, so we've got to be trending those and give prophylactic medications to help minimize those. For the hypogammaglobulinemia, that again is directly related to the lymphodepleting chemotherapy, and also the CAR T cells effect on the B cells and the reduction of the plasma cells. Usually that's just monitored closely, and patients are monitored for recurrent infections. Rarely do they require immune globulin therapy or supplementation. With any of the cytotoxic agents and also the cellular manipulation, there's a risk of secondary malignancies and also late complications. So while they might be done to get through the acute phase, we continue to have to monitor them for long-term effects as well. And then just a quick word on the bispecifics. Some similarities in the toxicities in that we can see the neurotoxicity, ICANS, and the cytokine release syndrome. But the neurotoxicities are relatively infrequent with the bispecifics, except with the exception of one, and that's blinatumomab, which may be due to the longer time that a patient is exposed to the agent because it's infused over several weeks in the hospitalized patient. And so those patients, so with the exclusion of blinatumomab, the other bispecifics tend to have a low percentage of neurotoxicity. And it tends to develop either concurrently or very shortly with the CRS, very similar symptoms. The CRS, the cytokine release syndrome, again, the same kind of syndrome. It's typically with the bispecifics occurs within that first 24 hours. So it doesn't tend to be over the several days. It tends to be first 24 hours at treatment initiation and during a thing that we call the step-up dosing, because the bispecifics, many of them are dosed in a step-up fashion to help mitigate or prevent that development of these toxicities and to get to the maximum tolerated dose. So typically, again, occurs earlier on in the therapy, and again, even if it's given intravenously or if it's given subcutaneously. Tumor lysis syndrome can occur with the bispecifics as well. The same with the infection, and then as Dr. Lebec mentioned, with the bispecifics, we're at risk for developing some of those on-target, off-tumor toxicities that can sometimes develop, and that has to do with the actual antigen that's being targeted. And so you've got those, there's several different antigens that are targeted. So in the interest of time, I'm not going to go through each of the individual ones, but they can be just slightly unique depending on the target. So I think
oh my gosh,
I hope we've
that
covered
was
a lot of that.
amazing. That was amazing. So there was a lot of information that was just shared from these two amazing women understanding the side effects of CAR T and bispecific. Important that this is also a field that is actively changing, quickly being updated. The guidelines, the names, originally it was just CRS, now it's CRS and ICANS, not CRS and ICANS and IEC. Again, multiple different things, and the medications are changing as well. So if you're in the emergency room or urgent care and you're seeing these patients, basically it's really just about identifying it could be that and getting them to the right experts too. It may not all be on you to do all of the treatments. But in summary, we just want to talk a little bit about cytokine release syndrome, right? Kind of from the two specifics from the CAR T, probably within 3 to 5 days versus hours. Very similar fever, hypotension, you have to kind of take a look at. Often in CAR T, because of how targeted it can be more severe. Right now, we're still treating with IL-6 treatments. And the tumor burden really makes a difference about the severity. And so we're just kind of still taking an eye on this. The neurotoxicity, really important. We don't like to melt brains. Cytokine release from the CAR T versus the bispecific are a little different. Again, with the bispecific, usually hours. CAR T can be a little later. We really have to think about how people are thinking, seizures, headaches, right? It's not a stroke, and how you think about it. Can be very severe in the CAR T. IL-6s and IL-1s can be treatments here too. So other diseases and other treatment blockers to think about. And you probably will need long-term treatment for these things, and they have to be watched closely. The cytopenia, so basically, you just don't regain a cell line after the chemotherapy for whatever reason, or there's an autoimmune phenomenon that's causing one of those cell lines to just not be present, whether it's neutropenia, anemia, platelets, or all of the above. With CAR T, it can often be late. So it's something to keep an eye on again. So if they had CAR T 6 months ago, now they're coming in for their third bronchitis or third UTI or GI bug, something going on, or sepsis. What are we missing? What are the labs? How do we think about this so they can get to the right help? So they're not just using the emergency room. Same thing with the bispecific. Usually it can be days to several months. So just things that we have to kind of look at and watch and may or may not recover. MAS or IEC, I feel like it's really interesting. Every single disease state defines HLH or macrophage activation syndrome or immune effector syndrome. Everyone has their own alphabet soup. Fundamental or similar principles of a cytokine release with a little bit more of this presentation of the hepatosplenomegaly, the cytopenias, the fever, kind of look like CRS, but doesn't, has a higher ferritin, low ESR, elevated LFTs. Again, IL-6 can be used, IL-1s can be used, steroids can be used. Still something that you likely will admit them for, and they will be seen. As you can see, as I'm not an oncologist, I'm a rheumatologist, we have a pharmacist, we have oncology. We're all a different team here. A team-based approach is really, really, really important to these patients. and how we manage them both short-term, long-term, in the hospital, outside of the hospital, so they do their best and they can have the best outcome. So if you're in an emergency center, your urgent care, trying to figure out who those key players are in your system that do this, it's almost like a graft versus host disease in that sense of the cellular therapies. So if you need help, who to call, and how that system works to get them in, to get them treated. You know, the other thing that we have to think about is leave you with some SMART goals, which are, I tell my medical students all this time, right? Smart, measurable, attainable, relevant, and timely. So how can you do this? So how you rely on your team members to move through, what are the teams, how should they do it? This is pretty common. And the more that we evolve in immunotherapy, CAR T, and BiTE cells, the more we're going to see these autoimmune phenomena. So the better we have to think about it and the better we have to get at this. And it's going to go to this approach that, one, we're all immunologists. Sorry, guys. Two, how do we think about these diseases? How do we get better actions? And how do we create better systems to keep them out of the hospital? And then I'd also like to thank CEC Oncology for providing today's program, as well as our speakers, and for bearing with us. I don't know where everyone is listening, but currently it's like -10 degrees in the East Coast. So thank you for listening to our audience. And thank you. We are the emergency care for patients with cancer receiving CAR T cell and bispecific antibody immunotherapies, experience serious adverse events. And just let us know what else we can do if you have any questions.